It gives me great pleasure to speak about orthodontics to you all today. I have been in the field since 2008, and also to show what an orthodontist does and to increase the awareness of orthodontics among the medical professionals as well as the general public. So before I go on to orthodontics, I would like to talk a bit about dentistry. Well, at the dental faculty, we have a 5-year curriculum which includes 10 semesters, and then our graduates earn the BDS degree, following which they have a 1-year internship period, and after that, once they obtain the SLMC registration, they could either join the health ministry, the university, or the private sector. So far, up to now, we have graduated dental surgeons all over the country only from the Faculty of Dental Sciences, Peradeniya. But lately, we have a new faculty at the Javadanapura University, but still, no dental surgeon have been graduated from there. And then once they graduate as dental surgeons, they could do their postgraduate studies if they want to. And in dentistry, we have 5 main fields. That is restorative dentistry, where the dental surgeons, where the postgraduates could specialize in crowns and bridges, implants, and advanced restorative techniques. And oral and maxillofacial surgery, where all surgical aspects concerning the face and neck, head and neck area is they are trained on them. And oral pathology, community dentistry, and they could also go into administration and orthodontics. Right, so when I talk about orthodontics, the term orthodontics gives it's a Greek derivative. Ortho gives the meaning of straight and dontics gives the meaning of teeth. Well, orthodontics is a branch of dentistry that leads with the correction of malocclusion, and not only malocclusion, genetic variations, facial form, and function of the oral cavity. So orthodontics is not just straightening of teeth, but it's a field where we give hope to our patients by producing a beautiful smile so that they could face the society with confidence. An orthodontist has to be trained for 3 years in the registrar period, and then SR period for 1 year, after which they have a foreign training of 1 year as well. For now, in Sri Lanka, we have only less than 40 qualified orthodontists all over the country, working in several government units as well as the private sector. And there are also about 10 to 15 postgraduate trainees currently training in our main teaching hospital units. What is our goal? When we look at our goal is to improve the function, the aesthetics of the patient, social status, and also by correcting the teeth, we improve the oral health of the patient. But as I said earlier, this orthodontics is basically something to do with aesthetics. The patients who come to us don't tell us, doctor, I have a problem with the function of my teeth, but they come and tell us, doctor, I don't like what I look like. I don't like the procline teeth, the teeth which have come forward, or I don't like the alignment of my teeth. So that is what they request. So even though the orthodontists may find several problems, it is extremely important that we address the patient's complaint first, because that will give the patient satisfaction. Even if at the end of the treatment, if the patient is not satisfied, but if we feel that the function is perfect, then that won't be of any use. Well, orthodontics is not something that popped up in the recent years. It is dated back to the Egyptians. They have found this picture shows us a picture from the teeth of a mummy, where they have put a metal band around the teeth, hoping to straighten the teeth. So it started during days back to the Egyptians, but the father of orthodontics, Dr. Edward Angle, was the one who first postulated the proper theory of occlusion in 1890, and that is what we follow up to date. Like I told you earlier, when we look at the need and demand of orthodontic treatment, we have criteria that we follow when we, especially in government units, we have this IOTN ratios where it is called the index of treatment need, where we look at the patient and we categorize them according to the treatment need. But then again, there is also individual demand versus the professional need. So in spite of all this, we have to think of the patient's need first and then go ahead with the treatment. The only problem that we have in our government or university units is the number. Because orthodontic treatment is costly, the amount of patients we have is high. We often have to go through a waiting list for the patients to undergo treatment. So then we have to look at the treatment in need and then prioritize the patients who really need the treatment before we start the treatment. So if we look at the prevalence of malocclusion among the society, currently there are about 80% of the child population with some sort of malocclusion. Well, this has increased in the recent years, I suppose, because now the patients and the parents are more aware of malocclusions, and most often parents bring children as small as 3 to 4 years. If they look at their teeth and find any abnormality, they bring them at that age. So which means the awareness and the availability of orthodontic treatment has increased. So because of that, the prevalence has increased. And at the same time, with evolutionary changes, the jaw size has reduced, and the number of teeth, the size of teeth also has reduced, resulting in an increase in the malocclusion. Other than the child population, we see an increase in the treatment need in adults as well, because of the availability of treatment and also an increase in the awareness. My oldest patient that I have treated was 72 years, and she was 74 when I completed her treatment. So I have been getting patients who are well above 60 who find that because of the availability now, they also want to get their teeth straightened. Right, so what are the causes for malocclusions? When a patient comes to us and then we look at the patient and we explain to the parent, look, your child is having maybe proclined teeth, a prognatic mandible. The first question they ask is, Doctor, ඇයි මේක මෙහෙම වෙලා තියෙන්නේ? So they expect me to give them an answer, like they think that there is a deficiency in calcium, or if there is some problem in their pregnancy which has caused these malocclusions. But no, none of these affect the malocclusion. Mainly it's the genetic expression of each and every individual which causes the malocclusion, especially in a certain malocclusion known as class 3, which I will be describing later. We see this tendency of genetic predisposition when we ask the patients if any of the family members have this problem, and they give a positive answer. Now this picture shows the Habsburg family of Australia, which is a royal family, who each and every member of the family had this prognatic mandible. So that is the fact that actually gave way to do research to see whether the class 3 malocclusion has a genetic predisposition. And other factors such as habits. Now habit is an extremely biggest problem of the malocclusion, because most often the children have a habit of either digit sucking, teeth sucking, pencil biting, nail biting, which is very difficult to control. Now, before we start orthodontics, it is always best that we have to stop the habits. The habit is best stopped when the child starts to get the permanent teeth. Otherwise, the malocclusion created by these habits could be established and treatment could be difficult. But even if there are certain malocclusions or problems which occur in the dentition with which is habit related, we can it corrects automatically if the child stops the habit at the correct age. But again, there is a problem if the child is having a habit like a tongue sucking habit or a lip sucking habit. It is very difficult to treat. So then we have to think of giving them some sort of appliance so that they could habitually stop this. Then also there are local factors which which result in malocclusions, such as early loss of deciduous dentition, over-retained deciduous teeth, late eruption of permanent teeth, and the presence of supernumeraries. I have some photographs here. Now, as you see, a supernumerary is an extra tooth which erupts. It can erupt into the mouth or it can be impacted, which hinders, as in this case, the eruption of the permanent incisors. But here it has erupted between the two incisors, and definitely with extraction it can, when we take out the supernumerary, it can leave a space here, so which creates a malocclusion. So likewise, in this photograph, you see over-retained deciduous incisors which have not exfoliated, but the permanent incisors are erupting behind the primary incisors. But what happens is, when this happens, there is a abnormal path of eruption of the incisors, and the incisors will probably erupt behind the lower incisors, which is called a crossbite, which needs correction to get the proper occlusion. Then in this patient, the primary canines or the C's have been extracted earlier, or may be extracted or may be exfoliated, and you can see there is no space for the permanent canine to erupt, and then the patient will develop crowding. Here, in such a case, this canine tooth is impacted, and it would not erupt into the proper line of the arch, again creating a malocclusion. Then this is one of the biggest problems that we see among young kids in our country, where with consumption of high amount of sugar, they end up with cavities in their posterior primary molars. And then what happens when the primary molars provide the guidance for the permanent premolars to erupt. So once the tooth substance is lost due to caries, what will happen is there won't be space for the eruption of the permanent premolars. So then they end up with crowding. So what I need to get across is that when small children with any of these type of problems, if you come across any patients with this type of problem, please refer to an orthodontist or orthodontic unit, so that these problems can be solved early and we can prevent development of a severe malocclusion and also by increasing the cost of treatment. Okay, so when do we start orthodontics? We have several stages of orthodontic treatment. So we start with preventive orthodontics. Preventive orthodontics is what we do for the primary dentition, like I said earlier, to prevent development of a malocclusion. Now, let's say this primary second molar was lost early due to caries, and then we have to maintain the space until the patient is about 13 years for the eruption of the second premolar. So then, when we look at this patient, we have provided an appliance called the distal shoe, where we maintain this space until the permanent tooth erupts. So it is extremely important that if any patient has lost the primary molars early, we have to maintain the space so that we don't develop crowding. So that's preventive orthodontics. And another aspect is the habit, where often parents bring their children to us asking what to do, right? But then these habits are often very difficult to control. Of course, we do preventive orthodontics. We give an appliance called the habit breaking appliance, but it is important to remember that we provide the habit breaking appliance only if the patient comes and tells, I want to stop the habit, but because I have been continuing for a long time, it's difficult for me to stop it in the night. So most often these children, once they are about 10, 12, they don't suck their thumb or digit during daytime, but it automatically happens during the night. So when it comes to that stage, if the patient wants to stop the habit, that is when we have to provide them with a habit breaking appliance. If not, we can induce a lot of psychological trauma on the patient, because when we put the habit breaking appliance, the patient cannot put the finger into the mouth. The second stage, that is once the patient is about 10 years until the pubertal growth spurt, we conduct interceptive orthodontics. And this problem, now I showed a picture earlier where the incisors were over-retained and the central incisors have erupted palatally. So it's a situation like this where we have to push these two incisors forward, otherwise it gives an unwanted space on the lower incisors. So this is interceptive treatment where we give a removable appliance to correct this problem and push the two incisors forward. Then we have the corrective phase of orthodontics where we give fixed appliances or any other removable appliances once all the teeth have erupted to correct particular malocclusions. Then there are cases once the patient is 18 years where we have to do corrective surgery, orthodontic surgery, in order to correct certain malocclusions where we cannot correct it solely by doing orthodontics. So it's orthodontic surgery. So that is we do orthodontic surgery once the patient has finished the growth or after 18 years. Again, another service that we provide is for special needs patients. So we have cleft lip and palate patients whom we look after from the day they are born to until the day they become an adult. Because cleft lip and palate, there are several stages where the orthodontist plays a major role. Initially, the cleft lip surgery is done when the patient is 10 weeks old, but if it's a if it's a bilateral cleft lip, such as in this case, and the premaxilla is prominent, we give an appliance called the NAM appliance to reduce the prominency of the premaxilla, and then the surgery is much easier to conduct. And then when the patient is about 9 to 10 years, the orthodontist starts the major role in cleft lip and palate patients. Because once the palate surgery, cleft palate surgery, which takes place when the patient is between 6 to 12 months, once the patient is about 10 years, there is constriction of the upper arch because of the surgical procedure. So we look at these patients when they are 9, 10, and then we provide expansion appliances to expand the upper arch to gain space for the erupting teeth, especially the canine. And then if you see that the permanent canine is erupting into the cleft palate, we send them for bone grafting to the oral and maxillofacial surgeon, and then later on we align the teeth with fixed appliances. But in this process, if we find that we can't completely treat these patients with orthodontics alone, the patient might have to undergo orthodontic surgery if the patient has a constricted maxilla and a prognatic mandible. Then patients with certain syndromes, facial syndromes such as the Marfan syndrome, have a very high vertical height of the lower face and high arch palate. So in such cases, also we provide them with appliances so that they find it easier to masticate as well as breathe. Now I will go into the types of malocclusions. So the main type is class 1, where it is considered to be the perfect occlusion. That is what Edward Dangle spoke about. He did several studies, and then he said, this is what a perfect occlusion should look like. So what we aim at the end of our treatment is to achieve this occlusion. But even in this class 1 malocclusion, there is no jaw problem, there is no prognatic jaws or retrognatic jaws. They are all nicely aligned in class 1, but these problems can be there. So there can be a crossbite where the incisors are placed palatally, and the patient can have crowding. This is known as crowding, where there is no space for these teeth to come into the line of the arch. And again, deep bite, where the lower incisors are almost unseen, but these problems can create a lot of problems in the patient's teeth. Now, for example, in a deep bite patient, this can induce occlusal trauma, giving even the lower incisors, if it goes on for a long period of time, can exfoliate. And this is called the anterior open bite, where the patient cannot bring the upper anteriors and the lower anteriors together. So they find it difficult to eat, and saliva drooling and speaking, pronunciation, they find a lot of problems with these kind of things. So they all fall under the category of class 1 malocclusion. The second category is class 2 malocclusion. Class 2 malocclusion, where the top jaw is more forward than the bottom jaw. There are two types of class 2 malocclusions. The first type is where the incisors are severely proclined, and you will see a big gap between the upper teeth and the lower teeth. And the second type is where you have retroclined anterior incisors with proclined lateral incisors, which is a special malocclusion called class 2 division 2. But in this type of malocclusion, the facial features are very favorable, and they say most actors, and now of course they do plastic surgery, but they have this type of malocclusion because the facial features are extremely favorable. And then the third malocclusion is the class 3 malocclusion, where you will see a difference between the upper and lower jaw. The lower jaw is more forward, and in this type of case only we have to go through orthodontic surgery if the patient does not come to us at the proper age. But in class 3 malocclusion, of course, there are minor cases, not as severe as this, where we can treat with orthodontics alone. So if I talk about the timing of treatment, generally it is very important that all children should be screened by the age of 10 years or above, and referred to a unit for proper orthodontic treatment. But in cases where a patient has a crossbite, like I told you earlier, that should be treated as soon as possible. Even if the tooth is erupting at the age of 6 years, if it's erupting into a crossbite, the child should be given an appliance to correct this crossbite. Then habits, you have to stop the habits before the eruption of the permanent teeth. And in class 3 patients, like I showed you earlier, these patients should be seen and identified at the age of around 8 years, because when we start early treatment with growth modification, by restricting the growth of the mandible and increasing the growth of the maxilla, it's very easy for us to treat later. Otherwise, if you don't treat them between the age of 8 and 11, the skeletal tissues become hardened, and they have to wait until the age of 18 years to undergo orthodontic surgery. But if they are treated at early age, around 8 to 11, where we do a treatment procedure called the face mask therapy, or it's a growth modification, then the patient, of course, the mandible will grow until 18, but the patient can at least stay without going through surgery. Then again, the patients who have a very small or retrograde mandible, so opposite of class 3, also need treatment at the age of the growth modification, that's pubertal growth spurt, which is again a couple of years in Sri Lanka, 10 to 12 for girls, 11 to 13 in boys. That is the age that we should start treatment for these patients with a certain type of appliance to reduce the difference between the upper teeth and the lower teeth and to bring the mandible forward. But fixed appliances does not have an age limit. You can start even at the age of 7 to 8 years with partial fixed appliances, but better to start when all the permanent teeth have erupted, and then you can even go ahead even in adult patients. There is no age limit. What are the types of appliances available? We have two types mainly, removable and fixed. In removable appliances, we give a removable appliance only for one notch, mainly for the upper. And then we have an appliance called the functional appliance, and also the latest appliances are aligners. And then in fixed appliances or braces as we call it, we have metal braces, ceramic, and then we have self-ligating braces. So if you look at the removable appliance, the most commonly used type of appliance is the upper removable appliance, where we give a patient a removable appliance. Now, problem with this appliance is compliance depends on the patient. If the patient does not wear these appliances, then the effect would not be there. So here in this case, we have given the patient an upper removable appliance to push this tooth forward. If the patient wears this properly, at the correct time, the correct number of hours, then we can correct this within about 3 months' time. Then in a patient like this patient, he has severely proclined upper incisors, and during their small children, they run and play in school. So if they fall, and these incisors can get traumatized and even avulsed, that is, the tooth can come out. So it is our duty, if they come to an orthodontic clinic, we provide them with a removable appliance until they are in the growth spurt or until they can wear fixed appliances. We give a removable appliance just to reduce the proclination so that the patient is comfortable. So most often this type of malocclusion, patient's biggest problem is bullying from the peers. So that also will reduce with our treatment. And these are aligners, which is, I'm sure you all have heard of the Invisalign, but we have the homemade aligners now. So where we provide the patient with a removable appliance for both top and bottom jaws, where it is corrected stage by stage. We give different appliances which should be worn for a particular period of time, and instead of giving fixed appliances. So the second type of removable appliance is a functional appliance. So this is a boy from our faculty where we treated him. He had a class 2 malocclusion with a very retrognathic mandible. You can see the difference between the upper and lower jaws is about 8 to 10 millimeters. And then we gave him a functional appliance, which is a growth modification appliance. It has 2 appliances, one for the upper jaw and one for the lower jaw. What it does is the patient, when biting, has to bring the mandible forward and bite. Otherwise, he has to bite on these bite blocks, which is uncomfortable. So the patient brings the mandible forward and bite. And because of the available growth and the pubertal growth spurt, the temporomandibular joint gets remodeled, and like you see, his profile improves markedly. The only problem with these removable appliance is the compliance. Patient has to wear the appliance the nominated number of hours, otherwise you can't get a positive effect. So these are again other functional appliances. These are some of the latest techniques that we use. This is called a fixed functional appliance or class 2 corrector, where we use it with fixed appliances in patients who are at the end of the growth spurt. So growth spurt is not a must in class 2 correctors. We put it even at the end of the growth spurt, and they are used with fixed appliances. So advantage in these appliances is that you don't need the compliance of the patient. It's fixed to the mouth. The patient has to wear it, and any adjustment can only be done by the clinician. Then treatment with fixed appliances. So this is the most commonly used appliance at the moment. We have different types of fixed appliances. We have metal braces. We have ceramic braces, which are tooth colored and very aesthetic. And lately, we have the self-ligating braces. Now, the difference between these two is you can see a tie around the bracket, which ties the wire onto the bracket in these patients. So the friction between the wire and the bracket is more. But here, there is no tie which binds the wire to the bracket. It's inside a small cavity, so the wire is free to move, and then there's less friction, so tooth movement is faster, and we can go ahead with this type of braces even where we extract or take out teeth. In these cases, we can go ahead with non-extraction, that is without taking out any teeth, effectively in self-ligating brackets. And then we have the lingual brackets, but this is very difficult to use. And also even for the clinician, it's very difficult, but they are more aesthetic. So we have aesthetic brackets, and which are more suitable for adult patients. But for young patients, I would always recommend the metal braces. So this is another case. This patient has a class 2 division 2 malocclusion with a very deep bite. The patient came to us around the age of 10 years, and then he had a full complement of teeth. So we have placed fixed appliances, and then I haven't put the middle one. We also gave him a fixed functional or class 2 corrector once the teeth are aligned, and now his occlusion looks like this. His facial profile has improved. As you can see, his smile has improved. More teeth can be seen. So this is the type of work that can be done with fixed appliances. And this is another case. This girl found it difficult to bring her upper and lower teeth. There is a gap between the teeth. The posterior teeth are touching, and the tongue comes in between these teeth. So what we did was, this is a new type of appliance where we intrude the posteriors. We used 2 implants in the posterior segment and intrude the posterior, so that we are able to bring the anterior teeth together. So after this appliance, the patient went through fixed appliances for both top and bottom, and she ended up like this. So fixed appliance treatment has advanced very much these days, and we are able to play around with a lot of problems and then treat them effectively at a very young age. Then also, other than just orthodontics, we combine our treatment with other disciplines as well. So we said we have oral and maxillofacial surgery, restorative dentistry, and then periodontal treatment. Periodontal treatment is where the patients have a lot of gum problems, and especially in the adult population. So this is Sagarika. She's 45 years, and she came to us with not us actually. She presented to the periodontal clinic because her teeth were mobile, shaking, and the teeth have come out, and the appearance doesn't look very nice. So they did the periodontal management on this patient and referred the patient to us, and then we placed full fixed appliances on both upper and lower teeth, and then she was able to have a beautiful smile as such as this. So here what we have done is we have improved her confidence, her facial profile, her aesthetics, and given her a beautiful smile. At the same time, the most important thing, we have reduced the development of a periodontal disease so that it's easy for her to clean, and once she maintains, she will have a full complement of teeth until a much more older age. So if she remained like this, she would probably have lost most of her teeth by the age of 50. So we combine orthodontics treatment with periodontal treatment to improve the function and the health of the patients as well. And this girl, she didn't have her lateral incisors. They were missing, like I told you, with evolutionary changes. Some of the teeth are missing from the arch. So she had the two lateral incisors were missing, and she had a edge to edge bite. The incisors, upper incisors, were biting on the lower incisors. There was no space in the arch. So if we tried to close this space, we would have found a Sunday-bite, which is the uppers would be behind the lowers. So what we did was we placed the fixed appliance, and then we opened up space for the two missing teeth, and then we referred her to the restorative unit where they were able to place implants and crowns on these teeth, and her final smile end up like this. So we combine with restorative dentistry in many issues, like when another example is when a restorative dentist wants space to place an implant and a crown, and if there is no space, they refer the patient to an orthodontist so that we create the space, open up the space so that they have ample space to place the crowns. So again, it improves the function and the aesthetic of the patient. So this is a case where we combined oral and maxillofacial surgery with orthodontics. This patient had a class 3 malocclusion where she has a very prognatic mandible and then anterior open bite. We start this treatment when the patient is about 16 to 17 years, and then we continue orthodontics for about 8 months to 1 year. And then we refer the patient to the oral, and we of course, before we start the treatment, we have joint discussions with the maxillofacial surgeon as well. And then we decide what we need to do. The surgeon tells us whether we need to push the teeth back or bring the teeth forward, or what the orthodontist, what he wants us to do with the teeth, and then we act accordingly. And then finally, once the surgery is done, the patient goes through about 6 to 9 months of orthodontic treatment, and then they end up with a very pleasing profile and jaw relationship as well. Any questions so far? Okay, if we look at the duration of orthodontic treatment, usually if the malocclusion can be treated with removable appliances only, it takes about 12 to 18 months of treatment, and then following retention. But if it's a simple malocclusion, if the patient is compliant, we can correct it within about 3 months. Then we have two-stage treatment as well, where we use removable and functional appliances along with fixed appliances. That, of course, takes about 2 to 3 years, because we start early during the growth spurt and then continue until the patient is at the end of the growth spurt. Otherwise, there can be relapses. Then if we do fixed appliance treatment only, it takes only about 12 to 18 months to complete treatment. And then what happens after orthodontic treatment? So once we give an appliance, we correct the occlusion. Do we leave it? No, we can't, because what we have done is we have moved the crowns of the teeth, but the teeth have roots inside the bone as well. So then we need to bring a weight until for a period of time, so that the roots will move into the new positions of the crown. But then for that to happen, it takes about 3 or 4 years. So until then, if we leave the teeth, we take out the appliance that we place. It could be fixed appliances, it could be removable appliances. If we just leave the teeth, what happens is the teeth take the easiest path, and the crowns move into the position of the roots. So it is essential that we provide the patient with a retentive appliance, where we hold on to the crown of the teeth and then wait until the roots move into their new position of the crowns. Now, this is extremely important, because most patients, once the malocclusion is corrected, they forget about the retention. But once it relapses, they come back to us and say it has relapsed. So then we can't do anything about it unless we give another appliance. So it is very, very important that this retention appliance is worn for at least 2 to 3 years, and then once full time, and then night only to continue. In a young patient, we continue until the growth phase is completed, but in an adult patient, we continue throughout life, at least in the night, because otherwise there can be relapses. So when we are wearing a removable or especially a fixed appliances, we have to take into consideration many facts. One is maintenance of the oral hygiene. If you don't maintain the oral hygiene, brush properly, use interdental brushes to brush between the braces, and then do the brushing technique properly, we end up with something like this. You will see increased swelling of the gingiva or the gum, and bleeding, and the patient will have pain. And when we take out the appliance, the patient can end up with a lot of other problems. So during treatment, the patient has to be very good in maintaining oral hygiene. If the patient is not good, then the clinician has to take the responsibility of referring the patient to a periodontologist to improve the oral hygiene. Then the diet is also very important when we especially with the fixed appliance in the mouth. This fixed appliance is placed so that we remove it after a year or so. So it's not highly glued onto the tooth, so it can come out. So if we don't follow the instructions given by the clinician, then there could be bracket breakages, which results in abnormal alignment of that particular tooth, pain to the patient, and other problems created with the broken or fractured bracket. So it's important that diet should comply with the appliance, and the patient should follow the instructions accurately or up to as much as possible, which are given by the clinician. And then also regular follow-up is important. Now, in a patient who goes through fixed appliances, it takes about 1 year to 1 year and 1.5 years to complete treatment. So the clinician needs to see this patient every month in order to go to the next step. So if the patient does not come on time, there could be problems such as bracket breakages and unwanted movement of teeth, which could result in the not getting what we have aimed for. So we won't be able to achieve the end result properly if the patient is unable to come for regular follow-ups. So, what are the risks and complications of fixed appliances or any of the um, orthodontic appliances? So, main problem that we have is root resorption. Even with fixed appliance, we see a root blunting, which should not happen in patients. And then, in removable appliance, if unwanted force is directed to the tooth, the tooth even can get non-vital, and then root canal treatment should be done. Then decalcification, like you see in this photograph, can happen when we take the brackets out, and if the oral hygiene is not good, patient can have a lot of caries, and then if you don't wear the retainer properly, you will end up with relapse. So there are risks and complications with wearing any appliance, but it is important to follow the instructions and do the thing properly if you need a pleasing smile. And also now I urge the pediatricians, when you see patients early screening and early referral is very important. And also if any of the patients have syndromes, they should be again referred to an orthodontist early. Then the only contraindication that we have in orthodontics is epilepsy. So what we find is that patients come to us even with a history of epilepsy. They are on medication. They say they haven't had incident in the recent past, but what the American Association of Orthodontists suggests is that we wait until at least until 2 years once the patient has completed the medication, stopped the medication, and the patient has not had an episode of epileptic attack. So that should be for 2 years. Then only we can give an appliance, because even if we give a removable or a fixed appliances, if the patient has an epileptic attack, the patient can aspirate any of these small parts, and then that can be deadly to the patient. So if a pediatrician or a general physician, if you see a patient you're seeing a patient with epilepsy, it is better to refer to an orthodontist with a recommendation that the patient is all right when referring the patient. And also with antibiotic prophylaxis, we prefer patients, because it's not a must that we give antibiotic prophylaxis, because we don't do any invasive procedures in orthodontics, but it is better if we know if any antibiotic prophylaxis is recommended. Then the ENT surgeons, I think mouth breathing is one of the main causes for malocclusion at the early age due to prominent adenoids. So what we do is, even though we correct malocclusion created by mouth breathing, that is the upper incisors come forward, the gums look red, the patient breathes through the mouth, we refer to an ENT surgeon so that they could see if the adenoids are prominent, and then do something about it, because then that will be easier for us to correct the malocclusion. But because if that does not happen, then again what we do is no use, it gets relapsed. And in patients with sleep apnea, we have appliances that we use for patients who have sleep apnea, who find it difficult to breathe in the night. So referral to an orthodontist would be favorable. So at the end, I would like to give a summary of the scope of orthodontics. What we do, we improve the facial and dental aesthetics of the patient. We provide a psychological benefit and increase the self-esteem in the patient. We eliminate trauma to teeth at a young age, and also we improve the oral hygiene and function. So thank you very much. I would take this opportunity to thank the KSM, Kindly Society of Medicine, for giving me the opportunity to increase the awareness of what and the role of an orthodontist and what needs to be treated and when they should be referred.